Welcome everyone. This is lecture 24 of the series of lectures on fluids and electrolytes. These lectures are based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This is the book. You can find it on Amazon as an ebook or as a paperback. I'll provide the link in the description below. If you have not subscribed yet, please subscribe to the channel. Today we are going to start chapter 3, Hyperkalemia. If you would like to know more about physiology of potassium, you have to go back to the lectures on hypokalemia. I'm not going to repeat anything. Now, hyperkalemia is defined as potassium over 5.5, but you have different definitions. The laboratory might consider hyperkalemia above 5.1, depending on the lab. Some studies used 6, so there are differences there. For our purposes, it's going to be around 5.5 or higher. What about the prevalence of hyperkalemia? Hyperkalemia is seen in hospitalized patients and community-dwelling subjects. It is not as common as hypokalemia or hyponatremia. In the Rotterdam study, and we talked about that when we talked about hypokalemia, they studied 5,000 community-dwelling patients aged 55 or older. Hyperkalemia was defined as potassium over 6, and in that study they found that 0.7% of patients 75 or older had hyperkalemia, so not very common. Other electrolytes problems such as hyponatremia and hypokalemia were not restricted to a certain age group. So why do we see hyperkalemia in older patients? Because of chronic kidney disease, of course. So the prevalence of hyperkalemia increases as the incidence of chronic kidney diseases increases, therefore it increases with age. In the same study, hyperkalemia was associated with higher mortality. We have here a odds ratio of 1.42, again because of concomitant chronic kidney disease. A study in about 8,000 patients admitted to the emergency department found hyperkalemia in 1.8%, and in hospitalized patients is seen in 3%. Now we're going to spend this lecture and the following lecture at least on the etiology of hyperkalemia. Now, hyperkalemia is rarely seen due to increased intake of potassium because the kidneys have amazing ability to excrete potassium. If you increase your intake of potassium from the usual intake of about 100 milliequivalents per day to 400, you will only get a slight rise in potassium if your kidney function is normal. So the urinary excretion of potassium is really good until you reach advanced chronic kidney disease stage 4 and usually stage 5. The kidneys can adapt. So our focus when we are talking about hyperkalemia is on two things. Do we have kidney disease, acute kidney injury or chronic kidney disease, or do we have a decrease in aldosterone activity? We said the main factor in the excretion of potassium through the kidneys is what? Aldosterone. So decreased mineralocorticoid activity, decreased aldosterone activity, whether decreased aldosterone secretion or resistance to the action of aldosterone are the two main causes of hyperkalemia. Okay, let's summarize. Hyperkalemia is either renal or adrenal. Okay, other things are not as common. We're going to discuss them in some detail, but remember, hyperkalemia, renal or adrenal causes. Okay, what about transcellular shift of potassium? Can potassium shift out of the cell? We said that the cells are full of potassium, okay? Most of potassium is intracellular, okay? If some potassium inside the cells shift outside, then we're going to get hyperkalemia. That's possible. Pseudohyperkalemia is not very common. Many times we have multiple factors, such as you have someone with diabetes who has hyporeninemic hypoaldosteronism with chronic kidney disease. On top of that, the patient may be taking an ACE inhibitor, an angiotensin receptor blocker, or a spironolactone. Maybe the patient is dehydrated. All these factors together contribute to hyperkalemia, especially if we have dietary indiscretion. So many times you have more than one factor. Let's look at some of these causes. Pseudohyperkalemia. When do you see it? Not very common. Maybe in patients with thrombocytosis, occasionally if you have really high platelet counts. Sometimes with severe leukocytosis. We said in AML you can get hypokalemia because these white blood cells will uptake the potassium. But also potassium, if the sample is sitting for too long, can be released from the cells and causes the opposite, hyperkalemia. Now, if you apply the tourniquet too tightly, then you can get hyperkalemia from trauma. Many times you see in the report sample may be hemolyzed, so you have to repeat it. So if the red blood cells are hemolyzed, they're going to release potassium and you are going to get an erroneous reading. So if you get a hemolyzed sample, please repeat it before you take any action. Now, let's talk about transcellular shift of potassium. So potassium is mainly inside the cell. If it shifts outside, you are going to get hyperkalemia, although transient. So an increase in serum osmolality like hyperglycemia and normal anion gap or non-anion gap hyperchloremic metabolic acidosis, also known as mineral acidosis, like what you would see with diarrhea, for example, is normal anion gap acidosis, can result in transient shift of potassium extracellularly. So the potassium shifts outside. On the other hand, with high anion gap metabolic acidosis, all organic acidosis, usually that doesn't happen. Okay, so patients with diabetic ketoacidosis who can get significant hyperkalemia, their hyperkalemia is not due to the organic acidosis, not due to ketoacidosis. It's due to insulin insufficiency or deficiency. Why? Because insulin deficiency is going to reduce the activity of the sodium, potassium, ATPase pump. This pump is going, what does it do normally? It's going to pump sodium out and is going to pump potassium in. So if it's not working, potassium is going to stay where? Out. So you're going to get hyperkalemia. How do you treat that? Well, you give insulin. Once insulin is working, potassium is going to be pumped back in. So also with diabetic ketoacidosis, the patient is usually very dehydrated, so they are in acute renal failure oftentimes, so you don't have enough renal excretion of potassium, and this is another cause for the hyperkalemia. But anyway, the role of organic acidosis, ketoacidosis, the anion gap acidosis is minor. Now, sometimes you get profound and severe hyperkalemia. You even dialyze the patient, and 2-3 hours later, the potassium is high. In those cases, please think of tumor lysis syndrome, rhabdomyolysis, and severe hemolysis. Okay, check a CK. Make sure the patient is not hemolyzing. Tumor lysis syndrome is usually obvious. So in those cases, you really have to check potassium frequently, and you may have to dialyze the patient frequently to just keep up. So in those cases, you get potassium sometimes 8 and higher. So if that happens, please check a CK. Look for a reason for rhabdomyolysis. Okay, do you have ischemia? Do you have trauma? Do you have cocaine abuse, heroin abuse, etc.? Now, why? Someone might ask, why in normal or non-anion gap acidosis, also called mineral acidosis, we have potassium shift? Why does potassium shift outside? Why do we get hyperkalemia? While in high anion gap metabolic acidosis, also known as organic acidosis, this doesn't happen. This seems strange because in both cases you have acidosis, so hydrogen is up. So why does one causes hyperkalemia and the other one does not? That seems perplexing. Okay, so this is what happens. In normal anion gap metabolic acidosis, mineral acidosis, hyperchloremic acidosis, the hydrogen moves into the cells. So hydrogen is high outside the cells, so it has to go in the cells, into the cells. So to maintain electrical neutrality, potassium has to go out. So hydrogen is positive, potassium is positive. So if we have a positive charge going in, we need a positive charge to go out. So hydrogen will go in, potassium will go out, so we maintain electrical neutrality. Now, what about chloride? If chloride would go into the cell with hydrogen, we wouldn't have that problem. But the cell membrane is really not that permeable to chloride. So hydrogen goes in, potassium goes out. Now, in organic acidosis, like lactic acidosis, like ketoacidosis, when you have high beta hydroxy butyrate, this doesn't happen. Why? Because the organic anion can cross the cell membrane with the hydrogen. So hydrogen will go up, but beta hydroxybutyrate will go up. So hydrogen will go into the cells and beta hydroxybutyrate will follow along. Lactate will follow along. So there's no reason for potassium to go out because both will go together, meaning a positive charge and a negative charge. Now, I have to say that in lactic acidosis, we can see potassium shift, but this is not due to the exit of potassium from hydrogen entry. It's due to damage to the cell membrane. So you have cell ischemia, you have loss of membrane integrity, and potassium can shift out. So let's look at this diagram. So the explanation I just provided is kind of crude, but this is actually what happens on a molecular level. So in mineral acidosis, hydrogen is up and bicarb is low. Okay, that's simple enough. That's the case with any acidosis. So on the apical membrane of the cell, this is a muscle cells, we have a hydrogen sodium exchanger and also a sodium bicarbonate exchanger. Since hydrogen is already up, there's no need for this exchanger to work very hard, so hydrogen doesn't get pumped out of the cells. And the same way, bicarb is low, so there's no need for bicarb to be pumped back into the cell because it's low outside. So both transporters then are not going to pump enough sodium into the cell. So the sodium inside the cell will go down. So this is going to affect the sodium-potassium ATPase pump. Since sodium is already low, there's no need to pump it outside. So since that doesn't happen, then potassium stays outside. It doesn't get pumped into the cells. So this is the real reason why potassium is shifted outside, why it stays outside. Also, a little bit of the chloride, because chloride is high, a little bit of chloride goes into the cells and then bicarb will have to go out, and with that goes more potassium. So this is the complicated explanation. Now with organic acidosis, also known as anion gap metabolic acidosis, okay, here the situation is different. Now the MCT is the monocarboxylate transporter. So this transporter, MCT1 and MCT4, not only will it transport hydrogen into the cell, but with that goes the organic anion. So here also the hydrogen is up, the bicarb is low, but with the hydrogen we have an anion like beta hydroxybutyrate, like lactate, so both will go into the cells together. So since both are going into the cells together, electrical neutrality is maintained. So the hydrogen sodium exchanger, the NHE1, will continue to work like normal. Now the sodium 3-bicarb exchanger also will continue to work normal, business as usual. So the sodium inside the cell will remain as usual, normal, or even a little bit high. So the work of the sodium-potassium ATPase pump will remain the same, so it will continue to pump 3 sodiums out and let 2 potassium to go in, like it always does, and therefore there's no change in potassium. There's no shift of potassium from inside the cells to the outside. Now, what about hyperkalemia due to transcellular shift in hyperkalemic periodic paralysis? This is a very rare disease. Attacks last less than 24 hours, usually 2 hours, less than 2 hours even. It's mostly in young patients less than 20 years old. It's due to a mutation in the sodium channel gene SCN4A. And it can result in severe muscle weakness or even paralysis. But because it's due to a shift, it's transient. Now, finally, like we said, high diet, supplements. Potassium containing salt substitute will not cause hyperkalemia unless the patient has advanced chronic kidney disease or hyperkalemic renal tubular acidosis or someone who's on dialysis, because the kidneys can adapt and excrete potassium under normal conditions. Now, on a test question, sometimes you can read case reports of severe hyperkalemia in people who would eat alfalfa or dandelion. I don't know why would anyone eat that, but they are herbal supplements containing those, so keep that in mind. I'm going to stop here and we'll continue talking about etiology in the next lecture.